Thank you so much for that great presentation. It was really fascinating to learn more about the seifer and how it came to be, and to learn about the changes in the seifer too. So now we have some time for questions from the audience. We have a few that are in the chat, and there's been some discussion, and I'm going to pick from those, but I encourage folks to add into the chat now if they have additional questions. And we're going to begin with a question from Lisa Jacket, who was commenting on one of the questions that happened earlier. She says, I'm wondering if you think that the expanded outer settings construct in the seifer 2 would make the seifer a better fit for the community-based service setting versus medical health services settings.
Yeah, that is a really great question. And in the literature review that I referred to, we had quite a few people touching on the need to basically abstract the seifer out further than just healthcare settings. That is the origin, that is the, kind of the root setting within which the seifer was developed. But with version 2, we will still be using health system language. We've had a lot of debates about this with our team. Like, if we don't use the word patients, what is another word that is abstract and generic and yet readily understandable? And we talked about, for example, if you've got interventions within a school setting, patients would be students, maybe teachers. Within a community setting, there are community health workers, there are families, and then there are children within the families. So, there are all these different kind of Venn diagrams and embeddedness depending on the scenario. We decided at the end, and I definitely would like to hear feedback if you have strong opinions about this, that when we write version 2, we will still use the language of patients, but we will have a section in the paper that will make it very clear with a concrete example about just substitute the word recipient or beneficiary or whoever the population of focus is for the intervention. We're also going to write a section on the importance of conceptualizing the boundaries between, the different levels. Within the seifer, we talk about the outer setting and the inner setting. And kind of conceptually, the inner setting is embedded inside the outer setting, and that dynamics from the outer setting affect what we do within the clinical setting or a school setting or a community or whatever. But there aren't always clear boundaries, and there are often more than two levels. We actually had some people say those two levels should be combined. And then we had other people say, you need to add, one more, two more, levels. So the important thing, and where we're kind of landing as a team, is to write about the importance that in the beginning to draw out your, your levels. And there may not be a perfect fit, but make it work for the work that you're doing. Do it in a way that brings clarity, conceptual clarity to your work, knowing that the closer you look at it, the more complex and dynamic those boundaries can get. But nonetheless, it is, and I've been, working on a lot of different projects, and there's always this kind of phase of the project where, when we try to draw out our relationships, our theoretical or conceptual model or framework for the project, we've got arrows, double arrows going everywhere. And then we go through this process of trying to simplify. Okay, what are the hypotheses? What are the key pathways that we really want to focus on, within this phase of the work that we're either proposing or that we're doing? And so there is this kind of iterative thought process, I think, as a team, as a research team, that is inevitable. And doing that work up front before attempting to apply the seifer is really important so that you get your language settled and you get the levels and the boundaries settled into how you're operationalizing it for your own work.
Thank you. On a related, I think this is related, I just want to ask a question that I was thinking of when you were presenting the data on how you used a quantitative analysis of the qualitative data and then examine the strengths of relationships between different constructs and outcomes. So I was just curious if you would say a little bit more about that process and how you took the qualitative data and then assigned values for that type of analysis so that you could really then support your theoretical questions with quantitative data.
Sure, that's a great question. So we do have a description of this process, and we also have all of the templates online on the seiferguide.org website. But I guess in a nutshell, it is important to keep the qualitative analyst blinded to outcomes. So just, kind of at a high level, when we're doing our assessment of context, we don't want to know what the outcomes are because we may be influenced knowing that, wow, these guys did great. And so everything's a facilitator and looking good. So you're blind to outcomes. Then for each, let's say that for each of our medical centers, we interviewed, 3 or 4 people. So there are a number of ways you can do this, but definitely it is important, I think, especially when you're using this framework for the first time and going through this process for the first time, to take a team approach and to have at least 2 people who are independently coding the qualitative data into the constructs, using the constructs as code. And we have an in vivo template, and we also have a code book in Word online that helps to operationalize the constructs for use as qualitative codes. We have some extra information beyond the published paper online, like about exclusions and differentiating between some of the key constructs that can be closely related or intertwined. So once you have your data qualitatively coded, then we go through and read the qualitative content and apply a rating based on, we've done it a couple of different ways. When we first started off, we actually did it person by person, so that we would apply ratings if the interviewee gave concrete examples of, like a barrier of how the new program, new intervention is not compatible with existing programs. And he or she gives specific concrete examples about why they think we would code that as a strong barrier. And then we would look for the level of agreement with our other interviewees. Now, this is a subjective process. We can't just take an average and say, well, what if all 3 of the other interviewees are, they didn't really identify this as a barrier, or maybe it was a weak barrier where they would just say, oh, it's incompatible, but they never really give concrete examples. In that case, we might give more weight to the people who are closest to the implementation. So in our case, for example, we interviewed providers who were not involved in implementation. They only kind of heard about it or referred patients to the new program. But, we captured their perceptions, but they may be kind of more at a high level. They may even conflict with the perceptions of the people who are at the core of the implementation. So that's why it's important to have more than one person reviewing the content And then we have discussions. A lot of times we agree and then we can kind of move forward. But a really valuable and important part of this process is when there is disagreement about whether it's a barrier or a facilitator, if it's a strong one or a weak one. We have these discussions, and through these discussions, we always come back out with a better, a sharper, I guess, interpretation of what's going on at that facility. So then we actually have a spreadsheet where we put in qualitative quotes that are, exemplar to support the ratings that we agree on and the rationale for the ratings. And then we look at those ratings and the qualitative data together. And only at that point, at that stage, do we then add in the outcomes data and look for those patterns. In this case, we had 11 sites. We were able to do correlations, but in a lot of our studies, we're doing kind of qualitative pattern, based on patterns of relationships between each of the constructs and outcomes.
Great. Thank you. That was very interesting. I have a question from Jennifer Gardner. She asks, would the idea of implementation phases be akin to the use of a plan, do, study, act cycles to drive iterative improvements?
Yeah, that's a great question. I have come to think about using quality improvement language, I have come to think of kind of traditional implementation as first order change. You can almost take a project management approach to, for example, hiring staff, finding space, getting the equipment in place, figuring out where your supply or how your supply chain is going to work for the materials and resources that you need to deliver the intervention. Identifying and maybe recrafting a clinical process to fit or integrate a new intervention. There's a lot of work in that realm that really is kind of a one-time, effort. And once you get the people in place, once you've identified the resources, where the supply room is going to be, what materials you need, et cetera, then going into this kind of optimization phase where we need to tweak, we need to continue to tweak. Or maybe we find out that primary care providers are way too busy doing other things, and we need to involve LPNs, for example, to do referrals. So that's kind of it. Let's test that in a clinic. That's a perfect candidate for doing a plan, do, cycle, act, or plan, do, cycle, plan, do, act cycle of change, and kind of testing and evaluating. Is it working to use LPNs under this, kind of circumstance? And just continuing to make those optimizations. And this is where, I'm really highlighting, I guess, the importance of clinical teams working together to do this, rather than relying on a single champion or a project manager or implementation lead to do all the work, and then making sure that it's going to be there, forever, or, until the next change comes along.
Thanks. The next question is from Alexandra Harper. She says, it seems evident that we need to engage clinician stakeholders in implementation efforts from the ground up. Do you have suggestions for balancing the time required for their involvement in research and the daily requirements of clinical care, and any strategy your team has found to be successful for getting hospital leaders on board with tapping clinician stakeholders, particularly outside of the VA, which she says an atypical system?
Let me tell you, we do not have nirvana in the VA either. We have, high variety across the system, but I also do acknowledge that outside the VA, there are also other pressures that we don't have. For example, reimbursement issues are huge outside the VA, and having those referral relationships can be very fragmented, more so than within the VA. But this also is a really important question. And I think this really gets at the crux of what we're up against as implementers, as implementation researchers. And that is that within and outside the VA, providers and clinical teams, their number one priority is to see patients. And I have seen articles in the media that literally, do like an analysis has been done and, oh my goodness, providers are spending, I don't know, 20% of their time doing quote unquote administrative work. That's wasted time. They should be seeing patients. And, so there's some of that kind of talk in the media. And then there's also pressure, of course, within the system, and especially again outside the VA, because there is a need for generating revenue, and also in so many places, demand exceeds supply. And so there's tremendous pressure on providers to see as many patients they can in a typical day. Where is the margin for, where is the absorptive capacity to absorb any kind of change? I mean, we're going through an enormous medical record migration now within the VA. In many systems, if you haven't already been through this, it'll be coming. Where is the margin to really kind of deal with a seismic change like that? And for that matter, any change that we come to the table with. And that is a struggle. And so in my work, what I'm trying to do more and more is to amplify the voice of the front line, because they're the people who are dealing with this tension of there is strong intrinsic motivation at the front line to improve things. I mean, you talk to anyone and they've got ideas about how to improve their work process, how to make things better for their patients, but they can't. And there is a level of frustration because they don't have the time, they don't have the ability to, do it in a team, that people may feel like they have to solve it on their own. And I think that a great antidote for, the burnout, the level of burnouts that we're hearing about at the front line would be to find ways to build this margin in so that teams can participate in this in this process of improvement, including implementation of new programs or practices.
So I think this builds on this discussion. Josh Johnson asks, could you expound on your point about the relationship between LHS or implementation science researchers and teams working on quality improvement in health systems? How can they partner to improve the rate at which new knowledge is gained and new practices implemented?
Yeah, another great question. And I think this is why it's important to establish measures related to employees, related to that are important for system leaders. And that if we can get measures, whether it's qualitative or quantitative indicators of, how do you measure knowledge acquisition? How do we measure and conceptualize quote unquote learning? And yet, I don't know, maybe I'm overstating it, but I think every health system talks about wanting to be a learning system, wanting to be high reliability, wanting to be, kind of continuous improvement. And they recognize the importance of this, creating this kind of culture, literally for their survival, because there are such big shifts going on in healthcare and pressures. But the reality is, in the day-to-day, that it is really challenging to do so. So like within the VA, we are rolling out, and there is high level leadership attention and priority on becoming a high reliability organization. And one of the pillars of that model, of that culture, is continuous process improvement, that everyone everywhere is involved. And so we are developing measures and working with partners within the system to develop measures of what does continuous process improvement look like, and how is our approach helping to promote that. So not only achieving the goals of our implementation, whether it's implementing a new practice or de-implementing, but that in addition, we have secondary measures around the level and the durability, I guess, of continuous process improvement, continued engagement. So when we're working with teams, 12 months, 24 months later, are they still working together? Are they still doing improvements?
Thank you. There's just a quick clarifying question from Carolyn Passarello. This, I think, regards the conversation we had earlier on plan, do, act. And she says, so it sounds like phases of implementation research are akin to a technical problem and then an adaptive problem. An adaptive problem is where the PDSA cycle would be applied. Is that accurate?
I think so. If by technical problem you mean that there is a problem that can be solved, or a goal, let's talk about it, in terms of a goal. We have a new way of doing something and we need to get it implemented. And it's just a matter of, bringing everyone together. I guess the drawing a line between technical versus adaptive, my only hesitation to do that is that ideally, there is also adaptation happening within that initial phase. So we're doing a diagnostic or an assessment of context. What are the current starting point clinical processes? Who's on board, who's not, going through all of those constructs that I walked through, and then adapting the intervention itself as well as the implementation strategies to have a successful initial implementation to meet those initial goals. But then, yes, after that point, there needs to be continued adaptive or optimization happening. And this is really kind of more at a micro level, where the frontline workers, employees, are really the experts on what that optimization, well, actually both phases, needs to look like, because you want to set yourself up for success by accurately adapting in the initial phase, but then continue tweaking and optimizing using those PDSA cycles.
Thanks. And before we wrap up, I loved hearing about the changes in the seifer 2, and I know that the seifer website has so many resources and is really very remarkable. When might the seifer 2 innovations be added into that website?
Well, I recently, number one, we have been accepted for a panel, an oral presentation series of presentations at the D&I conference in December. And we have committed as a team to get the paper under review by the end of the year. And these days we did plan to submit to Implementation Science, and they are putting the papers that are under review, they're posting them publicly on Research Square. So the manuscript will be available at that point, which is great. That's our goal, and I'm hoping. It's a lot of work, as you can imagine, just stepping through and then trying to fit it within the confines of word limits and all of that.
Yeah, absolutely. Well,
But it is fun and gratifying work.
this has been a really great discussion, and I thank you so much for presenting to us